Very good morning. I'm a traditional teacher, right? No magic. I'll start with very basics of manual therapy, which the beginners are supposed to know. I'll deal with a little bit of biomechanics, the normal pathological changes that occur in the spine with aging, how to evaluate, clinically diagnose, and therapeutically manage the various low back pain conditions we come across in our physiotherapy practice. You know, spine degeneration, spine is a rule rather than exception. There occur degeneration of the vertebral body, there occur degeneration of the disc, there occur degeneration of the facet joint with aging. You know the motion segment, the anatomical and functional unit of the spine is motion segment, right? Half of the vertebral body above, half of the vertebral body below with the intervertebral disc in between, the facet joint on both the sides, the ligament, the capsule, the muscle, the vessels that form the motion segment. You have got the intervertebral joint, you have got the facet joint, two facet joint that you know. These are the synovial joint. They are anatomically linked and functionally interrelated with each other. Movement of one is dependent on the other. If there occur any dysfunction, any abnormality in one, again that reflect in the other. Means if there is any problem in the facet joint, the intervertebral joint is going to be affected, and if there occur problem in the disc, intervertebral disc or intervertebral joint, then secondarily the facet is going to be affected. In almost everybody suffer with low back pain. Low back pain is considered as the second common problem in any OPD next to common cold. There occur degeneration of the bone, a gradual decrease in the cortical bone at 3% per decade in both the sexes, increases to about 9% per decade in postmenopausal women. A 6 to 8% decrease in the trabecular bone per decade begins between 20 to 40 years of age. In both the sexes, before 40 years of age, about 55% of the load-bearing capacity is attributed to the cancellous bone, which decreases to about 35% after 40 years of age. Bone strength decreases more rapidly than the bone quantity, which account for the end plate bending away from the disc, resulting in anterior wedge compression fracture. Now coming to the intervertebral disc, you know, intervertebral disc is a avascular structure, a neural structure. It derives its nutrition from the vertebral body above and below. You know, vertebral body is highly vascular. You have the cortical bone, you have inside you have the cancellous bone that is completely filled with blood. So from how the disc derive its nutrition, how it survives, the disc derive its nutrition from the vertebral body above and below by a process of diffusion. And for the diffusion, what is the criteria? For diffusion, you require a pressure gradient. If intervertebral disc pressure is less than the intervertebral body above and below pressure, then the disc is going to absorb the fluid from the vertebral body above and below. And when the disc pressure is positive, it releases the fluid into the vertebral body above and below. That means disc pressure changes is required for, getting the nutrition and survive. The disc pressure changes with various position, with the change in the position, with the activities. Right? The disc pressure is minimum in the semi-phallus position. In semi-phallus means in supine position, hip flex and knee flex, that is the minimum. And it further increases when you lie down supine with the straight knee. It further increases in standing erect, further increases in sitting erect, and further increases in standing and bending forward, and again further increases in sitting and bending forward. During the waking hour, most of the time either we are in sitting or standing, that means the disc pressure is positive. And during this waking hour, the disc releases the fluid into the vertebral body above and below, whereas in the night as you lie down, the disc pressure is less. So the disc absorb the fluid from the vertebral body above and below. That is the reason why throughout the night the disc absorbs the fluid. So at the early morning, the height of the individual is increased by a few millimeters, and at the end of the day, the disc releases the fluid and the disc height is going to be reduced. Somebody is suppose having some problem, low back pain, you go to physician usually advises us to go for the rest, bed rest. Even in our early days, we have seen people with back pain diagnosed as PIVD or so, and they apply plaster, POP plaster, jacket or plaster corset. So if the spine is immobilized, somebody is lie down for a long time, there occur no movement, there occur no changes in the intervertebral disc pressure. So the fluid exchange between the vertebral body and the disc is going to be affected. As a result, the disc undergo early degeneration. Deprived of nutrition, the disc undergo early degeneration. So for a healthy disc, what is required? Movement is required. Movement and activity is required, so that there will be alteration of the disc pressure and there will be alteration of the fluid exchange. The degeneration of the disc begins to occur in the second decade. That starts from the lower lumbar spine, L5S1 level, because the vertical compressive load is maximum in the lower lumbar region, right? So this degeneration begins to occur in the second decade. So what is that process? The process, you have got the nucleus pulposus. The composition of the nucleus pulposus is mucopolysaccharide plus water. About 85 to 90% of the nucleus pulposus is water content, and a few fibers are embedded, surrounded by annulus fibrosus. The collagen fiber are attached to the vertebral end plate. Vertebral end plate is a thin layer of fibrocartilaginous structure that separate highly vascular vertebral body from the avascular intervertebral disc, through which this diffusion process takes place. So in the second decade, the pores in the vertebral end plates start disappearing. That become progressively harder. So the process of diffusion is going to be decreased over time. As a result, the nutrition to the disc is affected. So the disc undergo degeneration. So what is that process? There is loss of mucopolysaccharide, there is loss of proportionate amount of the water content. In first decade, the water content is about 85 to 90%, and second decade it becomes 70%, third decade it becomes 50%, it reduced to 50%. And fourth decade, the disc is transformed into a fibrous mass. And after 60 years of age, the disc place is filled up by indistinguishable fibrous mass, scar tissue. You cannot differentiate which is annulus, which is nucleus pulposus. Scar tissue, a fibrous, inelastic, inextensible tissue, a thin layer is attached between the vertebral body. As a result, what will happen? The intervertebral mobility is going to be affected. That is what we say stiff spine or spondylosis. Then what about the annulus fibrosus? Annulus fibrosus also undergo degeneration. In about the third decade, as the abdomen bulges because of accumulation of the fat, because we are all settled, you get a job, you are married, right? So because of all those things, you have fulfilled all your aims, objectives, so the body weight increases. So as a result, the lordosis is increased. So what is the factor that is responsible for the lordosis? Cervical and lumbar lordosis is due to wedge-shaped intervertebral disc. That is, posterior height of the intervertebral disc is narrower than anterior height. In the lumbar region, your nucleus pulposus lies more posteriorly, it doesn't lie centrally. So what I want to say, posterior height of the annulus fibrosus is thinner, posterior width of the annulus fibrosus is thinner. As such, your annulus fibrosus in the lumbar region is posteriorly is weaker. With increase in lumbar lordosis, what happens? There is posterior compression, anterior distraction. That means the load is transferred into the posterior element. Posterior element that include your posterior annulus fibrosus. So posterior annulus fibrosus is now subjected to increased vertical compressive load. As a result, what happened? It fell, probably because of the increased load, it fell and cleft appear in the annulus fibrosus. With again advancing age, this degeneration of the annulus fibrosus also progresses. The number of cleft, the size of the cleft gradually increase. So what is the function of annulus fibrosus? It keeps the gel-like nucleus pulposus in its place. So as you bend forward, so yesterday Deepak sir was telling, as you bend forward, what happens? Nucleus pulposus is compressed anteriorly and tends to move backward. That is resisted by the annulus fibrosus. And your posteriorly annulus fibrosus is reinforced by posterior longitudinal ligament, that you know. But with the degeneration of the posterior annulus fibrosus, now nucleus pulposus tends to move back, means it tries to exert a horizontal pressure over the posterior annulus fibrosus, which has to be resisted by posterior annulus fibrosus. But with degeneration, it probably fails to resist that load because it is already degenerated, through which now it ruptures, through which the nucleus pulposus bulges. That is what known as your prolapsed intervertebral disc, herniated disc lesion or slip disc, whatever. McKenzie say it is a derangement syndrome because the normal arrangement, centrally located nucleus pulposus is bulged posteriorly. And usually what happens, the direction of bulge is posterolateral. Right? Why it occurs in the lower lumbar region? Just we have discussed now, in the lower lumbar region, the vertical compressive load is maximum. The annulus fibrosus is relatively narrower, weaker, and the posterior longitudinal ligament is again narrower in the, that you know, in the cervical region it is broader, gradually it becomes weaker. So these are the factors why the prolapsed intervertebral disc is more common in the lower lumbar region. L5, S1, most of the cases or few cases you may find it L4, L5 level. Then what is the other factor that is predisposing to this lesion? There are other factors like, if there is facet asymmetry, in the lumbar region the facets are lying in the sagittal plane. And during movement, what happens? Flexural movement, what happens? The inferior articulating facet of the vertebra above glide superiorly upward, bilateral symmetrically, over the inferior articulating facet of the vertebra above glide upward over the superior articulating facet of the vertebra below, bilateral symmetrically they glide. So that what happens? There is anterior compression and posterior distraction. Posterior distraction is proportionate to anterior compression. Anteriorly जितना compress होगा, posteriorly इतना distract होगा. That means the intervertebral space is expected to remain constant. The volume is expected to remain constant. When the volume, intervertebral space, intervertebral volume remain constant, obviously the pressure remain constant. But in case of facet arthropathy, suppose there is a sacralization, unilateral sacralization, or there is a asymmetrical facet arthropathy. Facet arthropathy, what will come to later on. That means in that case what happens? One side facet is hypomobile, other side is mobile, moving normally. So as I bend forward, what happens? Suppose my right side facet arthropathy I have developed, or sacralization of right side developed, then as I bend forward, my movement will be something like that, asymmetrical. The trunk deviates to the affected side because my right side facet is not gliding as it should. There occur anterior compression, but there is not posterior distraction as it should. So what will happen? The intervertebral space is going to, the volume is going to reduce, the pressure is going to increase. As a result, the disc bulges backward. So that is one of the precipitating factors or predisposing factor for your facet arthropathy. Similarly, suppose there is hypomobility. You know, thoracolumbar spine is hypomobile. Your cervicothoracic region is hypomobile because they are the transitional zone. You must be knowing what is transitional zone. आपका facet orientation suddenly change from the C7 to T1, from D12 to L1. So that is the reason why these are the relatively hypomobile segment. When my thoracolumbar junction is hypomobile, obviously my lumbosacral junction become hypermobile. There occur compensatory hypermobility at the lumbosacral junction. अब कोई पेशेंट को अगर प्रोन लाइन में अपर लिम्ब पुशअप करके देखेंगे और स्टैंडिंग में बैकवर्ड एक्सटेंशन करके देखेंगे, you will find there is a deep crease at the lumbosacral junction. That indicate there is a segmental hypermobility. When there is excessive movement, what will happen then? It will undergo degeneration. Obviously, more wear and tear. And more wear and tear lead to again your disc lesion. When the nucleus pulposus bulges posterolaterally, what will happen? Mild bulge, it will compress the annulus fibrosus. You know, the outer 1/3 of the annulus fibrosus is neural. There is some nerve bending present, some vascularity is there. So compression of this outer annulus fibrosus, which is neural, will obviously give rise to low back pain. And you know, low back pain is a common condition. Everyone gets sometime or other low back pain. So with little low back pain, individual continue to perform with activities. कुछ medicine लेता है और with some home treatment, one continue to perform with activities. What is our activities? You know, our almost all activities involve flexion. In the morning you get up, as these students are showing, right? We brush, we take bath, we go to our workplace, sitting, right? Almost all our activities in sitting. Hardly you do any activities in standing. You know, your standing, walking, or any overhead activities involve extension. If you are lying in prone, your spine is extended. Otherwise, almost always your spine is flexed. So one with little low back pain continue to perform his activities that involve morning to evening flexion, then what will happen? Then this bulge is going to progress. As it progress, it may posterolateral क्या है आपका? You have got the intervertebral foramen. So it become a content of the intervertebral foramen. Now coming to the boundary of the intervertebral foramen. Intervertebral foramen का boundary क्या है? Anteriorly you have got the vertebral body above and below with the intervertebral disc in between. Posteriorly you have got the facet joint. Superiorly, inferiorly you have got the pedicle above and below. What is the content? Content क्या है? Spinal nerve root, right? So spinal nerve root is going to be compressed. It may be compressed. And if it is compressed, one develop radicular pain. And in those cases, if somebody gets a pain, one try to adopt a posture where the pressure over the spinal nerve root is going to be less to get relief of the pain. One adopt a posture. What is that posture? There will be, the lordosis is reduced and trunk may be deviated away from the painful side. That patient himself develop that posture. That is what Sujata madam was asking yesterday, compensatory. That position is a compensatory sciatic scoliosis, we say. And about 90% of the cases, the trunk deviates away from the painful side to get relief of the pain. If you try to correct that posture, the pain is going to increase. After the trunk deviation, that is known as listing, so pain is going to aggravate. If you go for extension, with extension, your intervertebral foraminal size is decreased. Already the volume of the content kya hai abhi? Now what is the content of the foramen? The disc is the content of the foramen. Volume of the content is increasing, size is decreased. So pain is going to aggravate. And during flexion, what happens? The disc tends to move back. So now the volume of the content, though the size of the foramen is increased with flexion, but the volume of the content is increased because more bulge, there will be increased bulge. Right? So again, with flexion also, the pain is going to increase. And if the lateral side flexion, the pain is increased. This is the clinical finding, right? This is the clinical finding in those cases. Tippani de. This is we have already discussed. So this is again article published, sacralization or herniated disc. There is a strong correlation. So now, there is, we have got the Mohanty concept that deal with the spine. Mohanty says, derive the pain into two types that you know. One is your chemical pain, other is your mechanical pain. And low back pain, most of the low back pain is mechanical. About 85 to 90% of the low back pain is mechanical. We are in the panel discussion, we are discussing yesterday. Low back pain, it is classified into specific and non-specific low back pain. Specific is where the specific diagnosis can be done. Non-specific, no specific diagnosis is done. In specific low back pain also, there will be some mechanical. Specific means your spondylosis is a mechanical. Your disc, what is that? PIVD is also mechanical. Disthesis is also mechanical, right? Apart from mechanical, the others are chemical. Chemical means if there is some infection, inflammation like your ankylosing spondylitis, your tuberculosis, right? There may be some secondary also that give rise to low back pain, right? So these are the red flag for your physiotherapy or manual therapy. What is mechanical pain? Any mechanical pain. What is that? The pain is reproduced with mechanical distortion of the structure. Mechanical distortion कैसे होता है? When you load the tissue, आपका plus 2 में हम तो पढ़े होंगे ना, there is x-axis, the load y-axis, there is elongation, right? So when there is loading means as you perform the movements, our body is subjected to two kind of load that your external load, internal load. External load is nothing but your gravity, your body weight, and internal load is your muscle force. As you do the movements, activities, change in the posture, the pain is reproduced, that is your mechanical, whereas in chemical pain, since there is inflammation, as the inflammatory exudate, as long as the inflammatory exudate accumulate and irritate the nerve ending, there will be pain. Pain is almost continuous in nature. Probably intervertebral disc lesion is one of the PIBD is one mechanical problem where the pain in acute stage is continuous in nature. So, in Mohanty concept, Mohanty divides the spinal problem into three categories. One is your postural, other is your dysfunction, other is derangement. Postural, when you adopt a particular posture, one gets the pain. People say, as I work for half an hour, 1 hour, I get the low back pain, I get the neck pain, right? With the change in posture, the pain disappears. So when you are sitting for some time, your body is subjected to gravitational load. So there is a creep phenomenon, biomechanism malum hoga. With the load remaining constant, there occur further elongation. Even the gravitational load is constant in your static posture. There is no movement in a static posture. Over time, due to creep phenomenon, there occur further elongation that give rise to pain. That is the physiology of your postural syndrome. Other is dysfunction. Dysfunction means there is limitation of the movement. There may be adaptive shortening or so, there is limitation of the movement. Movement will be limited in some direction, and at the end range, one complains of pain due to elongation, stretching of the tight structure. And derangement is, as we have discussed, the normal arrangement of the nucleus pulposus and annulus fibrosus is disturbed. Nucleus pulposus may be displaced from its original position and give rise to pain. Mohanty developed its own protocol to, there is evaluation finding to diagnose those problems, whether it is dysfunction, derangement. In Mohanty concept, in the evaluation, the unique thing is you have to go for the repeated movement, right? In movement evaluation, you go for the repeated movement. For the lumbar spine, you go for the repeated flexion, repeated extension in standing and lying. So with repeated movement, the derangement is characterized by repeated movement in the direction of derangement centralizes the pain. What is the direction of derangement here? The posterior derangement. So posterior derangement means as you do repeated extension, the pain is going to be relieved. Centralization means the pain may be, if one complains of pain on the foot, gradually it ascends up toward the spine. Or maybe the intensity, the course remaining constant, maybe the intensity is going to be reduced. To start with, beginning, maybe there was 9/10 in VAS, and progressively as you do repeated movement, the pain intensity is going to be reduced. Right. So how to perform that repeated movement? There is a method of performing the repeated movement. You slowly move to the extreme range as possible. मेरे को backward bending करना है तो you try to move as much as you can, but slowly, and maintain that position for a few seconds. Right, and come down to the resting position slowly, just like a trapezoidal curve, and that should be done repeatedly, without any rest, without any break in between, 10 to 15 repetitions. During this movement evaluation, suppose the pain aggravates, then you stop the movement and do the movement in other direction. So if there occurs centralization, it is diagnostic of derangement syndrome, and again, if it is diagnosed as derangement syndrome as per the Mohanty, you have to manage the patient with same repeated movement. So what we have discussed again, in case of derangement syndrome, there occur a trunk deviation, that is known as listing. In listing, what is the pathology? The facet joint, the contact between the facet is lost, partially lost. So how do you do the repeated movement? आपको repeated extension तो करना है ना? That is the method of treatment in case of derangement. So with repeated extension, what should happen? The facet should glide, the inferior articulating facet should glide downward over the superior articulating facet, but it has lost its contact. It cannot glide now. So what you have to do then? You have to correct the listing correction. You have to correct that trunk deviation, has to be corrected before you go for the repeated extension exercise. You may get some patient who is having trunk deviation in standing, but it doesn't present in lying position. In that case, yes, you correct the trunk deviation in standing, and at the same time, you can go for the repeated extension in lying position. If you get patient who is having trunk deviation in both in lying and standing position, of course, you have to go for the correction of the listing first, then extension, or listing correction in standing along with extension. So we'll discuss that, demonstrate that, practical these things. This is about these are the various slide showing the listing correction repeated. We'll do all these things. Then what Syriac says, there is another concept known as Syriac's concept. What Syriac says about this prolapse intervertebral, you know, Syriac says disc is the source of all pain. All low back pain arises from the disc. Of course, that is not true. Whatever. You know, Syriac divides the disc lesion into two types. One is soft disc lesion, other is hard disc lesion. What is soft? Soft क्या है? Disc में. Your nucleus pulposus is soft. Annulus fibrosus is hard. So, again your PIBD, Mackenzie says it is derangement syndrome, and Syriac says it is a soft disc lesion. The clinical diagnostic criteria as per the Syriac concept is the patient is less than 60. Obviously, अभी हम तो discussion किए. After 60, the disc is converted into a fibrous mass. आप लोग देखेंगे कोई MRI 60-70 years का patient आता है तो the diagnosis come, it is a slip disc, you know, herniated disc lesion. But it is not your disc lesion because nothing is there to herniate. The disc is, what is that we will discuss later on again. You know, so patient is below 60. There is sudden onset of low back pain, and over a period of time the back pain radiates down the leg. That's what we have discussed. When you get the back pain, you continue to do the activities. Obviously, the pathology, worsen and pain radiate down the leg. By the time patient complains of leg pain, there is no more back pain. He no more complain of back pain. And if you go for the posterior evaluation, you will find the lordosis is reduced. The trunk deviate, usually the trunk deviate away from the painful side because that is a compensatory phenomenon. He tried to adopt a posture where the IB foramen is optimal and disc pressure is optimal so that there will be no compression of the spinal nerve root. As you correct the trunk deviation, the pain aggravate, then forward bending, backward bending and sideways, ipsilateral side bending reproduce the symptom. That is the clinical diagnostic criteria for soft disc lesion or herniated disc lesion. I repeat, there is a trunk deviation present, lordosis is reduced, patient age is less than 60, patient usually complain of leg pain, there is no back pain, and correction of the trunk deviation, forward bending, backward bending and ipsilateral side flexion reproduce the symptom. The mechanics we have already discussed because with extension, the foraminal size is decreased, there occurs narrowing of the IB foramen, obviously more compression, more pain, side bending also same thing, and forward bending, the herniation is increased, the volume of the content of the foramen is increased, so one gets the pain. So what is the management for this? Syriac says, you go for the traction. Correct, again, traction is not going to be effective in the presence of trunk deviation. Traction में क्या होना चाहिए? The facet should glide. The L5 facet should glide. Superior articulating facet should glide downward so that the foraminal size is going to increase. But again, for gliding, the contact has to be there. There is loss of contact because of the trunk deviation. Again, you have to correct the trunk deviation before going for the traction. And regarding the parameter for the traction, it is only described by Syriac. As far as I know, Syriac says, if the flexion is painful, extension painless, you apply traction in extension, which is painless, right? Flexion painful, extension pain free, so you apply traction in extension. Extension painful, flexion pain free, you apply traction in flexion. If flexion extension both are painful, apply traction in extension. How to apply traction in extension? That may be in supine lying with the leg straight with a roll under the lumbar spine, or maybe in prone lying. And for applying traction in flexion, supine lying, obviously hip and knees should be flexed. And we apply traction in prone lying. The reason is the type of machine we have in Indian traction machine. If you apply traction in supine lying position, वो जो traction का rope है ना, that is not, what is traction? Traction is axial distraction. It should be applied along the long axis of the spine. हमारा जो machine है, उसमें आप traction लगाएंगे तो you will find the rope is not axial. ऐसे axial नहीं रहेगा. That is going to something like this at an angle. If the traction is applied in an angle, then what happens? you resolve into two perpendicular component. Physics तो मालूम होगा, f sin theta, f cos theta. Your one component is going to, the cos theta component is horizontal, that is going to distract the spine, whereas sin theta component is perpendicular, that is going to tilt your pelvis forward, giving rise to lumbar flexion, which is usually not desirable in case of prolapse intervertebral disc. That is the reason I never apply traction in supine lying. Though it is said that in supine lying with the hip and knee flex, your disc pressure is the minimum, but there is another risk factor, the flexion component. It is going to add flexion component. So that is the reason why we apply traction in extension position, that is in prone lying. Then as per Sirius, again, what is the hard disc lesion? Hard disc lesion is, the annulus fibrosus lesion that occur above 60. Anybody complain of low back pain above 60, Sirius is hard disc lesion. So what is the clinical feature? One complaint of sudden onset of the pain, maybe low back pain or back pain with radiation. Both occur simultaneously. If at all there is back pain, this will occur suddenly following some forward bending activities, or there may be back pain as well as leg pain. Whereas soft disc lesion, back pain पहले होगा, 7 days, 10 days, 15 days के बाद leg pain हो सकता है, right? But in case of hard disc lesion, both back pain and leg pain occur simultaneously. There may be a trunk deviation also. What happened? What is the pathology here? The annulus fibrosus is torn. A piece of torn annulus fibrosus is displaced during the movement that impinge over the nerve ending, giving rise to radicular pain. So the clinical movement evaluation finding is flexion, extension and contralateral side flexion, opposite side head flexion for the patient. As you bend to the opposite side, now what happens? The affected side is open up. As it open up, the torn annulus fibrosus gets displaced and impinge over the nerve ending, giving rise to pain. And the management is various manipulation. Will show. Then there is another problem we encounter, that is lock back. What is that lock back? Lock back, the spine gets locked. Sometimes as you bend forward, try to lift something, your spine gets locked. It gets stuck in a position from where no movement could be possible. And they usually occur in the middle age. So what is the mechanism? There is degeneration of the disc that start right from the second decade, starting from the lower lumbar spine. With the degeneration of disc, the water content is reduced, the disc height is reduced. When the disc height is reduced, what will happen? The vertebral body above subluxates downward. That means that segment become hypermobile. That segment become hypermobile. So when the segment become hypermobile and you try to bend forward, in that case what happens? Normally what happens? During forward bending, just now we are discussing, there is anterior compression, posterior distraction. Facet joint, the inferior articulating facet both glide upward symmetrically over the superior articulating facet of the vertebra below. And during re-extension, forward bending के बाद जब re-extension करते हैं, then what happens? The inferior articulating facet glide down over the superior articulating facet. So during this movement, flexion movement, what happens? Your capsule is stretched. Capsule is lined by the synovium, that is also stretched. And during re-extension, what happens? There is a ligament known as ligamentum flavum. That is the only ligament in our body which is elastic in nature. During flexion, that is elastic structure elongate हो गया था, right? And during re-extension, there occur elastic recoil of the ligamentum flavum. Ligamentum flavum का attachment कहाँ पे? कोठी? हाँ? In between the So elastic recoil of the ligamentum flavum, being elastic, it is elongated during flexion. Now it recoil because of that elasticity. It pulls the capsular fold and synovial fold out of the facet joint. When I bend, what happens? The sleeve is folded. During extension, that should be stretched out. Otherwise, what will happen? It is going to impinge between the facet. With aging, again, the ligamentum flavum also undergo degeneration. It loses its elasticity. It fails to recoil, and it fails to pull the capsular fold or synovial fold or meniscal body. Facet joint में एक meniscus होता है, fibrocartilaginous, out of the joint. If it fails, then what will happen? This is either the synovial fold or capsular fold is going to impinge between the facet. That is what known as your lock back. So if the back is locked, obviously no movement, facet is locked, no movement occur. The spine gets stuck and one gets acute pain. Almost similar to acute prolapse intravertebral disc, but the difference is in case of PIBD, usually at the onset one complaint of low back pain and later on leg pain, but here both occur simultaneously. Capsule is highly neural structure is compressed between the facet, obviously one should have severe pain. Pain and spasm and movement in all directions are going to be limited. But clinically differentiating factor is, there at the onset there may be leg pain, lordosis is usually maintained, whereas in case of PIBD, lordosis. If you can differentiate PIBD and your lock back can be managed by simple manipulation. Lock ke unlock karne ke liye manipulation. But in case of PIBD, if you go for the rotatory manipulation, obviously, there is no rotation of movement occur in the lumbospine. Very minimal rotation occur between lumbosacral region, and if you go for the manipulation in case of prolapsed intravertebral disc, that is again Syriac has mentioned that is the contraindication. Rotatory manipulation is contraindication of in case of soft disc lesion. So you may land in trouble. The condition may worsen. As a model today. So you have to take the history, right? In the history, the mode of onset is very important. Then the course of the pain that you have to. In physical evaluation, you make the subject stand with normal base of support. The reason is, with the change in base of support, the posture is different, the range of motion is again going to be changed. Right? Like, you make the patient stand, ask him to do the side bending. You see the finger to floor distance, right? Now you broaden your leg, move your hand. Now you see the range is going to alter. So to have a consistency in your finding, you have to ensure that every time you evaluate, the base of support remain constant. The posture evaluation kya karna hai? From the front, from the side, from the back, you see whether the head is in midline, shoulder should be level, bilateral arm trunk distance, right? Whether there is any trunk deviation, anterior superior iliac spine should be level, patellar normally faces forward, toe face outward, right? One time I always say, shoulder may be level, right? Whether it is normally level or level in elevation. One may be having shoulder level, but both the shoulders should be maybe depressed, not level. But which is normal, which is abnormal? You may say, somebody may say it is elevated, somebody else say it is depressed, but to find it out, you have to check the clavicular position. Normally your clavicle is oriented horizontally. So level of the AC joint, level of the sternoclavicular joint guide you to find out whether the shoulder is level normally or level with elevation, level with depression, or which is elevated, which is depressed. That you can find out. Right. Similarly, from the posterior view, again same thing, head midline, shoulder level, position of the scapula. Normally, both the scapulae should be parallel to the spine and away from the midline by 4 to 6 centimeter. Right. Posterior superior iliac spine should be level, your spine should be straight, gluteal fold, Popliteal fold, number of gluteal fold, the depth of the gluteal fold and popliteal fold you have to find out. The what is that? The tendon of Achilles should be vertical, the calcaneus should be vertical. If it is twisted, again that shows there is some foot deformity. And if there is foot problem, again that is going to reflect all over the body. That we will discuss later on. Then from the side view, from both the sides you see position of the head on the trunk, head of the head over the neck, neck over the trunk, right? Then scapula, whether protracted, retracted, your cervical lordosis, thoracic kyphosis, lumbar lordosis, ASIS, PSIS level, right? Normally what happens? In the most of the cases you find there is a head forward position. The easier way is to find out, you find out the tip of the mastered process, tip of the acromion, both should lie in the coronal plane. एक पेन पकड़ के देख लो whether it lies in one coronal plane or not, whether that is head is forward or not. Right, and for the lumbar lordosis, again, now usually what happens, your ASIS and PSIS is almost in the same level, right? Then comes the movement evaluation. For movement evaluation, usually people see the finger to floor distance, but for physiotherapists, finger to floor distance doesn't make any sense. Person with complete ankylosis of the lumbar spine could able to touch the floor with compensated movement from the hip. You have to see the patient, evaluate the patient thoroughly by checking the the skin, the creases and all properly. You make the patient stand and ask the subject to bend forward to touch the floor. Then you have to see whether each segment is moving or not. You have to see each segment is moving or not. चल इस पीछे इस तरफ each segment should be moved, right? Movement occur cephalocordally, movement occur bilateral symmetrically, right? With the forward bending, the normal lumbar lordosis is going to be reduced, it will become flattened, it becomes reverse. So finally you will have a posterior convexity, uniform posterior convexity है ना नहीं आपको देखना है. Quite thoroughly you have to find it out, because you have to note whether there is any segmental hypermobility or hypomobility. That is very important. Similarly, for extension, you place the hand and ask the subject. आप नीचे नहीं बैठेंगे तो properly नहीं होगा. Again, what happens? Movement should be bilateral, symmetrical, right? Movement occur cephalocordally, so lordosis is going to be increased, right? Bilateral fold देख लेना. Bilateral symmetrical fold होता है ना नहीं. In this boy, this side, particular right side, at the lumosacral junction, there is a shallow this thing, whereas here this is a deep crease. That suggests that probably on the right side the facet is not moving properly. There may be hypomobility, right? Similarly, again the side bending, you see the creases, this side how much it is stretching, right? Similarly the other side. So you have to check the active physiological movement is standing. The purpose of this movement evaluation is to find out which movement reproduce the original symptom. We don't find out the pain. You know, any movement will cause pain at the end range. Even normal individual, any movement will cause pain because of stretching of the structure. But we don't look for the pain. We look for the original symptom. You have to educate the patient. Tell me which movement reproduce the original symptom. Patient बोलेगा, yes, this movement original symptom. कहाँ पे? You ask the patient where exactly you feel the pain. पहले during the history you have noted the pain is here, and you see correlate whether it is the same original symptom or not. That is what very important. Repeatedly you ask the patient in your first evaluation to ensure which movement reproduce the original symptom. The movement pattern is normal or not. Where is that abnormality? Then only you can have proper manual therapy. Similarly, suppose your active physiological movement doesn't reproduce the symptom, then you apply the overpressure, right? Even overpressure doesn't reproduce the symptom, you can go for the combined movement. Combined movement, say extension is combined with side flexion and rotation. With extension what happens? Why you expect mechanical pen should be reproduced with the extension? You are loading the facet. You are with the extension. Your what is that? Foraminal size is reduced. If there is any foraminal problem, maybe the pen aggravate. If there is facet problem, pen aggravate. But with extension, probably the load is not sufficient enough. Patient को बोल रहा है मेरे को पेन हो रहा है, but it is not reproduced. Probably that loading is not sufficient enough to reproduce the symptom. In that case, you combine side flexion and side flexion and rotation, so that the foraminal size is going to further decrease. The facet on the same side is going to be further loaded. That may able to reproduce the symptom. Chalo. Next, you go for the इधर आना कहाँ जा रहे हैं? Passive physiological movement. This is a holistic movement evaluation. I am not going by any particular concept, right? It includes your both celiacs, it includes both, what is that, the McKenzie and all. Then you go for the passive physiological movement where, relax, पैर को bend कर. For passive physiological movement, for flexion, supine lying, bend both hip and knee, one hand over the bend knee, other hand over the pelvis. But here the problem is with the knee bending, the thigh touches the abdomen, the range of movement is limited because of the contact between the thigh and abdomen. Maybe in that case you can straighten the knee slightly and go for the movement. If you completely straight, you will have good mobility, but your, if there is sciatic tension and all, the condition may worsen. So you should be very careful. So with the knee slightly extended, you can have good range of lumbar flexion. And for side bending, in supine lying with the hip and knee flex, place your hand under the bend knee and therapy, even a person is obese, then you can, with your trunk movement, you can simply give the side bending movement. Right? Similarly, rotation also you can have to check. Next is side line. Side line. You go for the passive physiological movement with segmental palpation. Segment wise, you have to palpate to find intervertebral mobility, to find out whether there is any segmental hypermobility or hypomobility. So you place your hand, palpation आपको तो मालूम होगा, आपका जो dimple, posterior superior iliac spine corresponds to L, 2, S2. Your iliac crest, highest point of the iliac crest corresponds to your L4. That way you can, right? Bend the hip and knee, therapy stands on the front of the bend knee, place your finger in between the spinous process, right? With flexion, you expect the intervertebral space is expected to increase. Similarly, you move little more upward to find out the space between L4, L5. Again, move upward, right? At different, as you bend the hip and knee more and more, progressively you move your finger and palpate the gap. During extension, you stand in front of the thigh. By your trunk, try to bend this thing back, and again you should be able to find out the closing and the intervertebral, these things. For side flexion, you bend the overlying hip to 90 degree. The other one is straight. You place your heel of the hand under the ischial tuberosity, and your palpating hand should be on both the sides of the intervertebral space. जो spinous होता है, intervertebral spinous process का दोनों side में, you just place your thumb and finger. Then place your hand under the ischial tuberosity and therapist bend the trunk to apply side bending, right? Here the leverage is less, it will have little difficulty to give the movement and palpate. So as I give side bending, then what happens? The left side bending, then left side is closing and right side is opening. That intervertebral segmental mobility you have to check. Ulta. Ulta. For extension movement, the best way is in prone lying. Ask the subject to press on the hand and check the movement. Quite nicely you can see the mental mobility and interval. Check. Next, as per the metal arm. Yeah. Passive joint play, that is. The metal and part will do separately. Now you can go for the, as per the McKenzie, repeated movement evaluation. For repeated movement extension, you place the hand or the subject to press on the hand and raise. So what I told, you have to ask the subject to move slowly to the maximum possible limit. You have to keep a note of the range. Maybe from the shoulder to the table distance you can measure, right? In acute condition, definitely the patient is not going to perform this much of movement, so whatever. You have to keep a record. Why to keep a record? Because during this movement, you have to find out what is the intensity of the pain, what is the course of radiation. Suppose the patient performs less range, obviously the intensity is going to be less. As compared to the first movement, second movement he performed less. How will you know it is less or not? Unless you measure it, keep a note of it, you may not be able to know. So if you perform less range movement, obviously the intensity is going to be less. The course of radiation is going to be less. So that gives a false negative information regarding centralization of the pain. So you have to keep a note of this thing and keep on asking the patient where you feel the pain, what is the intensity, keep on asking. So, then coming to the treatment part, as per the McKenzie concept, you go for the, there are about 17 techniques, simple. The technique number 1 is simple, patient lie down in prone. Slide would have display kar da, McKenzie. Patient lie in prone. In prone lying, the trunk is in extension, the spine is in extension. You may get patient in very acute condition, you find unable to lie in prone. He has got so much of pain, and in very acute condition, the trunk is flexed. You will find unable to lie in prone. In that position, in that case, you put towel roll under the abdomen to accommodate the deformity. But he should feel little discomfort. It is not that. Make the patient lie down in relaxed position, completely pain-free. Because how will know otherwise if the pain is not reproduced? How will know otherwise there is centralization or not? After some time, you expect that the pain is relieved. If the pain is relieved, then you remove one towel so that the spine is progressively positioned in extension. Right? In